Shoulder flexion performed with the patient supine. Mainly this is a better position because they will be able to stabilize the thorax in this position. I'm sure you've seen in the clinic, a lot of therapists may measure shoulder flexion, abduction, and extension in standing, but you have to realize that there's no stabilization that is occurring for the trunk, and you have to make sure that you account for any of those movements, extra movements that you might see. Our access is going to be aligned with the greater tubercle of the humerus. Our proximal or stationary arm is going to be aligned with the midline of the thorax, and our movable arm is going to be aligned with the midline of the humerus. So in this position, once we have things aligned, we're going to ask the patient to come to the ceiling, bring the arm all the way back. I'm going to realign and make sure that I have everything lined up. My greater tubercle up here. I want to make sure that I am in the midline of the axis here, and I want to make sure that I'm in the midline of the axis at the other end of the goniometer as well. I want to take my reading in this position. This is another one where you have to be careful that you're not moving that stationary or proximal arm, and that you end up taking a reading like this because it will show significantly less range of motion than what the patient is demonstrating. Now, if your patient is like our patient here, they have too much range of motion, they probably have excessive range of motion, you can actually move them to the end of the table so that the arm drops off. Just remember, you still need to stabilize the scapula. So once I get them in this position, I'm going to take my reading and then go ahead and get a passive range of motion, and then I'll do my end feel. So once I have my active range of motion, I can then assess my passive range of motion and set the goniometer aside. You really want to stabilize the trunk here when you're doing your end feel. Of course, I want to be also much closer to the patient. I would not be standing this far away or off to the side. This is for educational purposes only. I want to get my hands as close together as I can. I should not be doing an end feel with my hand providing my force way out here or way down here, or just holding the wrist and pushing down. No, I want to stabilize as close as I can on both sides of the joint. This is going to be my stabilizing hand, so this hand is not going to move. This is going to be my force hand, or the side that I'm delivering my motion through. This is going to be very similar to when you do manual therapy, such as passive accessory motions and even manipulations, is you always have a stabilizing hand and a movement hand. So I have my stabilizing hand here, I have my movement hand here. I'm going to take up all the slack and give that little extra feeling for the end feel there. And in shoulder, we have shoulder flexion. Normal range of motion is 180 degrees, and our end feel should be firm and capsular. Shoulder abduction, we have the patient in the supine position, and our fulcrum or axis is going to be the anterior aspect of the acromion process. So we're not going to be exactly over the glenohumeral joint. It's going to be a little bit of a movable axis as well. And then our proximal arm is going to be parallel to the sternum. So here's my sternum in through here, and I can't do this directly from here to here, and so what I have to do is, again, align this so that my proximal arm is going to be parallel to the sternum, and my movable arm is going to be the midline of the upper arm and the midline of the humerus. Now, as this patient abducts, so we're going to ask them to have their thumb up towards the ceiling so that we don't impinge. And as they come up, you can see, obviously, my axis or my fulcrum, if you can come back down, is going to move pretty significantly. So where I start out here is not where I end up. And so I'm going to have to take that reading where my fulcrum is at the end. So I ask my patient to come all the way up with abduction. I put my proximal arm parallel to the sternum, and I'm going to be over that anterior aspect, what I'm assuming is the anterior aspect of the shoulder, and then I'm going to align with the midline of the humerus, and I have 180 degrees of abduction. I can go with some passive range of motion at this point in time and get my extra movement in through there. And then my end feel, I have to stabilize here. So I want to stabilize the scapula and make sure that it doesn't come out anymore. Get in nice and close. So typically, again, I'd be standing in front of the patient so I can get that nice end feel, and I'm going to take up the slack and determine my end feel, which in this case is a firm end feel. Normal range of motion is 180 degrees. Shoulder extension is performed in prone, and we're going to use the same landmarks that we did for flexion, which means the greater tubercle for our access, the midline of the trunk for the proximal or stationary arm, and the midline of the humerus for the movable arm. So we initially start off in this position. We ask the patient to raise their hand towards the ceiling, and we're looking at that shoulder extension here. So I align my trunk in this position. Remember, I want to double check. And I go ahead and look at my reading, which we have 74 degrees here. And then I'm going to do my passive, which I can get up to 85 degrees. I can set that down. Again, proximal here, distal, I'm going to move, and I'm going to get that little bit of end feel there, which again is a very firm capsular end feel. Normal range of motion is 60 degrees with a firm end feel. We had excessive range of motion here, and so this might be a good time to ask your patient if they played particular sports or if they do other activities where you would expect to see an increase in range of motion. With internal and external rotation, we actually have a couple of different positions that we can perform this test in. We can do it in a supine position, or we can do it in a prone position as well. The other thing here for the internal and external rotation, one of the things that you want to do is you want to make sure that the humerus is truly parallel to the floor, and so you may need to put a couple towels underneath the patient's upper arm to make sure that it stays parallel. This is because of the pectoralis major and minor can impact that range of motion, can change the position of the scapula. We want to make sure that we are in a neutral position as much as possible before we take these measurements. So my access is going to align with the olecranon process. My proximal or stationary arm can be in a number of different positions here. It can be parallel to the floor, so that would be right here, it's parallel to the floor, or I can make it perpendicular to the floor. I can also have this in an upright position or pointing down toward the floor. It doesn't matter, you just need to know where you're starting from. Obviously, if I start from this position, I'm starting with 90 degrees, and so I need to read a different part of the goniometer. If I start in this position, I'm starting at 180 degrees, so I need to read a different part of the goniometer. If I start here with them together, this is 0 degrees. Again, I need to know which part of the goniometer and which numeric scale that I'm using depending on where I start from. So we're going to start in this particular case with both of them up together. And then we are going to use, again, the midline shaft here of the ulna. And we could also use the ulnar styloid to point towards for my movable arm. If we're going to do internal rotation first, one of the other things that we need to watch out for internal rotation is you need to watch the shoulder coming up off the table. If you see the shoulder starts to come up off the table, that person has now gone beyond what is truly their internal rotation motion. So one of the things you may need to do is, as they do internal rotation, bring their hand towards the table is you may need to stabilize them a little bit at the shoulder to make sure that they are not then utilizing this motion and shortening the chest wall in order to gain excess motion. So this is one of the things that you need to watch out for when doing internal rotation. So I set my landmarks, olecranon process, mid of the shaft of the forearm here. And I'm going to ask my patient to bring your palm down towards the floor. And I'm going to follow that with my movable arm. Make sure that she's not coming up in this position right here. Again, I want to double check and make sure that my arm is truly perpendicular to the floor and that my movable arm is truly in the midline here. A lot of times we forget about that proximal arm, and so as the patient moves, we're starting to move this too, and we don't go back and look at this because we're so busy looking at this and looking at numbers. Remember, you have to kind of take an overall view here and look to see where we're at. And we're going to look at that measurement. Now again, I may need to stabilize. So what I can do, I can use my forearm, because if I come up to do my passive motion, she's going to start getting that shoulder rolling up. So I can come across here and just very nicely use my forearm to stabilize. And now I can do my passive range of motion. Take my second measurement in this position. And then for my end feel, we are now going to be using a little bit of a lever system in through here. Remember I said with flexion, your hands needed to be really close here. Well, it's hard to get that torquing motion for internal rotation in this position. I still want to stabilize proximally, but now I will be using this entire upper arm and a little bit of the forearm as my torque. And so I'm going to go take up the slack in the shoulder and do that little extra stretch at the end to get my end feel, which again should be a firm end feel. Normal range of motion, 80 degrees for internal rotation. External rotation, everything is going to be exactly the same here. I'm going to use the olecranon process. My proximal arm can be directly up, can be parallel to the floor, or perpendicular pointing down, does not matter. And I'm going to follow my movable arm and end up at the mid-range here, pointing towards the ulnar styloid. So I'm asking my patient to bring the back of the hand down, and she did readjust herself, so relax for a second. You may not want to see that, so go ahead and ask again, come on back down. And I'm going to read my goniometer in this position, perform my passive range of motion. Again, I'm going to stabilize proximal to the shoulder, use my torque arm here, take her to that end range, and get that little extra stretch at the end for my end feel. Again, normal range of motion, 80 degrees. End feel should be firm and capsular. We can also do shoulder internal and external rotation in a prone position, and our landmarks are going to be the same again with the olecranon process here. And again, my proximal or stationary arm can either be perpendicular to the floor this way, can be perpendicular to the floor this way, or we can start out with it parallel to the floor. It doesn't matter, you just need to know which numbers you need to read. So in this particular case, for external rotation, I'm going to ask my patient to bring the hand up towards the ceiling. I'm also going to use the same movable, which is the ulnar shaft here and the ulnar styloid. Take my measurement here. And then, of course, I'm going to do passive and do my end feel. For internal rotation, I'm going to ask my patient to bring her hand up towards the ceiling. And you can see here, sometimes this is a little bit nicer because remember in supine we had to block that shoulder to make sure that it wasn't coming up off of the table. But in this case, the table is actually doing that for us. And so we can see the big difference here with her range of motion, and she's not able to shorten that chest in order to bring the arm up more. So we're going to use the same motions here, do our active, do our passive, and then do the end feel.